Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out gasgasgas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, this is James at GasGasGas. This episode is going to smash the doors off Oxycodone. Now, when I actually first started anaesthesia, I definitely had not prescribed very much Oxycodone. It was always morphine and codeine and Oromorph on the wards, wasn't it? It's certainly crept in amongst the corners and the shadows over the last few years. It was always the drug we sort of went for when the patient had dodgy kidneys and needed pain relief. And I always was under the impression that it was actually quite a new morphine-like drug. Turns out, in 1916, in Germany seems to be a busy place for synthesizing opiates, they developed Oxycodone, calling it Eukodal, E-U-K-O-D-A-L. Now, apparently, this was a drug that was quite heavily utilized during World War II, and maybe Hitler had a penchant, or at least his physicians had a penchant for administering Eukodal. But bringing it up to the 21st century, 12th of March 2025, in the UK, Oxycodone loses its license for post-op pain control in its prolonged release version alongside prolonged release morphine, so you can only administer short-acting morphines now. Unless, of course, you go off license, which we don't not do. Anyway, so I mentioned Oxycodone and Germany, 1916. The company was Freund and Speyer, and they were fiddling about, as it seems quite a few pharmacists or chemists of the time used to. And from thebaine, they derived Oxycodone. So we could describe Oxycodone as a semi-synthetic opium alkaloid derivative derived from thebaine, Thebaine, thebaine. So why on earth did I think that Oxycodone was actually quite a modern opiate? Well, it's probably courtesy of Purdue Pharma. I'm sure you've probably heard of these guys. They developed a extended release version of Oxycodone and called it Oxycontin. And this was approved by the FDA in the United States in 1995. But what also came along with this FDA approval was a prolific, planned, and pernicious advertising campaign that framed Oxycontin as a drug that is safer than morphine, with lower addiction rates, less tolerance, and is less likely to be abused. And they thoughtfully targeted physicians. You know, everyone had a lovely time and probably had lots of dinners out eating steak, but that led to the massive uptick in prescribing of Oxycodone. Now, actually, Oxycodone possibly is a bit more addictive than morphine on paper, and it is, more potent than morphine, as we know. But I think the real nail in the proverbial coffin, if you forgive the slightly negative pun there, is that Purdue Pharma, owned by the Sackler family, is now bankrupt and having to invest heavily in programs to treat opiate addiction, and they got hit by a $6 billion fine. So it's there in black and white. What they did, bad. But the drug, maybe quite good. I had the misconception that actually took a while to work, wasn't very good, because, morphine takes a while to work, isn't very good. If you give someone IV Oxycodone, the onset time seems spectacularly fast, and they feel much better. I was stunned having administered an IV to an awake patient in ITU in acute pain once. I was like, whoa, gosh, shock horror, pain controlled. And it lasts for quite a long time. But, we all know that opiates are habit forming, so we need to be thoughtful and manage how we go about giving these and have plans for winding people back down and getting them off it when they don't require it anymore. Anyway, lots of waffling. You all know about prescription drug monitoring programs in the community, potentially co-prescribing naloxone on the wards, and I think that's now happening in the community as well in order to try and mitigate the number of deaths. Going to talk about the number of deaths later. We need to get into the bulk of the show. You're here to study for the FRCA, and I'm getting carried away, and it's minute 6. So, Oxycodone is an opioid. That means it's synthetic. It is available in immediate and modified release preparations, and the routes can be intravenous, oral, subcut, or PR, if that floats your boat. As we all know, it is a mu, kappa, and delta agonist, although, again, it seems to prefer mu somewhat. And we all know that opiate receptors are G protein-coupled receptors that ultimately lead to reduced synaptic transmission, and those pain signals aren't getting very far up the spinal cord, courtesy of its effects. But do remember that it's not just in the spinal cord that we find these receptors, but also in your brain. Its effects are sedating, anxiolytic, it's an antitussive, as are all opiates generally, and it causes some sedation and euphoria as well. Oh, this all sounds great. How do you dose it, you ask? Well, it is about 1.5 to 2 times the strength of morphine. So, generally speaking, if you've got a fit, healthy young adult who you would have given 10 milligrams of IV morphine to without really thinking twice, maybe give them 5 milligrams or 7.5 milligrams of oxycodone. Orally, it generally comes in at about 5 milligrams to start with QDS. So that's great. Now we know how to dose it, but what are the patients going to complain about when they have oxycodone? Well, they can get orthostatic hypotension apparently, but generally speaking, like with all opiates, it's a very cardiovascularly stable agent. It will cause respiratory depression. And remember, respiratory depression isn't just a diminished respiratory rate, but it might be worth thinking about it broadly as well. If they're not coughing as much, they're less likely to clear, they're more likely to get pneumonia. They might be breathing 8 times per minute, but actually they're not taking terribly deep breaths and they're getting basal atelectasis, another predisposition to getting infections and bugs. So not just a singular respiratory depression act. Centrally, from a nervous system perspective, we're going to see drowsy people, maybe they feel a bit good. If they have too much, they might start hallucinating, or if they're particularly sensitive, hallucinate, and you're more likely to predispose your patient to delirium if they're having lots of opiates. But these are all general opiate problems, not specific to oxycodone. As with all the other opiates, it makes you feel sick a bit, it can cause you to have constipation and reduce GI motility, it might put some people into urinary retention, and generally, it's an opiate. That's all fun and games, and you could pretty much spout that off for any opiate in the exam, and, they would respect that as a reasonable answer. However, kinetics, pharmacokinetics, they are particular to individual drugs, which is, deeply frustrating for all involved. So, we like to compare and contrast. Oxycodone, absorption, 60 to 87% oral bioavailability. That's really quite good. Morphine has a bioavailability of like 30%. That's why your 10 milligrams of Oromorph is equivalent to 3 milligrams of IV morphine per chow. With immediate release oxycodone preparations, the peak plasma concentration occurs in about 1 to 1.5 hours. How is it distributed throughout the body? Well, it is about 45% protein bound, chiefly to albumin. Its volume of distribution at steady state, which is a bit of a weird thing to suggest a volume of distribution as, is 2.6 litres per kilo. This is, I think, after a 4-hour infusion. It's quoted in one of those papers I've had the delight of reading to prepare for this show. It also crosses the placenta, and it is also found in breast milk. Now, something a bit more interesting is how is it metabolized? And I bet you can guess. It is chiefly metabolized in the liver. Ta-da! Much like almost all those other opiates, except for, you guessed it, remifentanil, which your plasma handles itself. So, we all know of CYP450 3A4 and CYP450 2D6, and those delightful little enzymes are busy with oxycodone as well. 45% of oxycodone is cleared by 3A4 into noroxycodone, which is weak, feckless, and doesn't really do very much. A non-problem. Whereas our dear colleague CYP450 2D6, which is a busy little enzyme, as we all remember now, converts about 19% of oxycodone into oxymorphone. This is a super duper potent active metabolite, 10 to 45 times busier than oxycodone, and really does like those opioid receptors. Now, generally speaking, if you took a cross-section of the whole population and then said, "Oh, is that oxymorphone metabolite a bother?" you would say, on average, no it ain't. However, in our unfortunate cohort of patients who are endowed with an exceedingly busy CYP452D6, an ultra metabolizer, then you're going to get quite a spike of that there oxymorphone, and you might actually have complications from it. Although it's very hard to tease this out of literature, isn't it? Because you've got to figure out who the ultra metabolizers are, and that's not very easy. You may also have another cohort within this group who has the opposing CYP2D6 polymorphism bother, where about 5 to 10% of Caucasians have no activity, in which case they might get less pain relief from oxycodone. Unlike with codeine, whereby they get no effect, because codeine on itself ain't really very busy, but once it gets converted to morphine by the liver, hey presto, you've got some pain relief. There is one more step in this whole pathway, and that is that both of these metabolites, noroxycodone and oxymorphone, can be converted into morphine. This is potent, but can't get across the blood-brain barrier. So now we've done loads of metabolizing and mixing and making in the liver, but how do we get rid of these things? Well, you've guessed it, it is the kidneys. So all these metabolites are kicked out into the urine. About 19% of the free drug is eliminated in the urine. 50% is conjugated oxycodone, and then they say about 14% is oxymorphone. Remembering there are other bits and pieces and metabolites and things that we're not going to talk about that also cleared in the urine. With the immediate release preparation, the elimination half-life is about 3 hours, and clearance is 800 mils per minute. Important things to note is that if a patient has liver failure, they're going to accumulate oxycodone, they're going to get encephalopathy, and patients with end-stage renal failure, they're going to accumulate drug, aren't they? The reason why I think we're a bit happier with oxycodone in renal failure than morphine in renal failure is the metabolites are less potent. Although if you are really deeply, superbly concerned, buprenorphine is something that is cleared entirely by the liver, almost entirely, and therefore really does dodge the renal problem. So how do we use oxycodone in the hospital? Well, it's approved for moderate to severe pain, chiefly acute pain, but also it's used in cancer pain and palliative care, and it's one of those drugs that you might rotate a patient onto to rotate them off something else if you're managing chronic pain. We need to be aware that giving it to someone for chronic pain probably doesn't help them very much, and the role of some of these pain clinics is actually to try and eventually reduce the opiate dependence in these cohorts. Now, what about abuse of this drug? So in the UK in 2023, 5,400 and something drug poisoning deaths. 47% of these involved an opiate, and mortality has doubled since 2012, and that's off the Office for National Statistics. The trends in the US, I think they've got a little bit more data in some ways, is 80% of overdose deaths are now fentanyl related in the United States, and that's probably because it's easier to transport, get across the borders, it's easily concentrated, and therefore, a kilo bag of fentanyl goes much further than a kilo bag of heroin. So overall, oxycodone, interesting history in that it was perhaps an excellent test case for proving how pharmaceutical companies really do need to be actually kept a bit of an eye on when they're getting up to mischief, like advertising drugs that are great when really they're secretly not, which does seem to happen a worryingly large amount of the time, especially when they refuse to compare their drugs against the competitors and only compare their drugs against previous drugs that they've already invented. But anyway, oxycodone, synthetic opioid, stronger than morphine, more bioavailable than morphine, so easier to give orally, perhaps more addiction forming, has the potential for some potent active metabolites, although on paper we consider them not to be terrible concern. And again, you just have to know about CYP2D6 and these patients. If codeine ain't working for them, then oxycodone is probably actually quite a safe choice, although they won't get as much of an effect as perhaps the average patient. So thanks for listening. I've tried not to ramble along too much on that. Like you, I'm excited to finish covering all the opiates, because whilst you need to learn them, and I'm glad that you're paying attention and learning about all these opiates, I'm excited to do something else, honestly, guys. So, we're going to get there. We'll be okay. We'll do it. We'll be fine. We are going to end our opiate journey on a high, pun intended there. We're going to do diamorphine, aka heroin, aka smack, aka star-spangled powder, skag, junk, black tar, talco, talquito, and basically anything you can really think of could probably be used to describe heroin, except for maybe, I don't know, Cheshire cheese. Oh no, that probably works too, actually. Anyway, cheerio! Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.